Hello and good afternoon to everyone, those who have joined the session. I can see Dr. Aisha Fakhur and Dr. Shahida, Dr. Osama, and Dr. Amber with us. Okay, so I would like to welcome you all on behalf of MedExam. This side Fatma from MRCOG-1. Today, we are going to host a free webinar on a very crucial topic, that is Mpox in pregnancy, which is also a recent UK guideline. Alongside with Dr. Desiree, she is a member of MedExam Experts since 2017, and it is an honor to have her with us. So I would like to once again welcome you all in the session. In case you have any queries, you can just raise your hand at the session end. Over to you, Dr. Desiree. Good luck.
Thank you, Fatima. Let me just share my screen. Hello, guys. So as you may know, we will be having a two-in-one webinar. The first part of the webinar will be telling you what is the best strategy to prepare for MRCOG Part 1 in 3 months. And then we will have a short introduction about courses. And then we will have the Mpox in pregnancy UK guideline, the recent UK guideline. So as Fatima have said, I've been with MedExam Expert since 2017, exactly like 7 years from now, 7 years until now. So let us start. I'm Dr. Desiree again, and welcome to MedExam Experts free webinar. So I know there are only 2 reasons why you are here in this webinar. First, you are planning to take the MRCOG Part 1 exam. And second, you are wanting to update your guidelines and your knowledge on the recent guidelines on Mpox in pregnancy. Either way, we welcome you because this is a weekend. We welcome you for joining us in this webinar. If you are planning to take the MRCOG exam, my best advice for you right now is 3 months before the exam is to stop dreaming and start doing. Because the best challenge at this point in time is to maintain your motivation and momentum over this period. You think about possible disruptions like work, family commitments, and you should plan accordingly. I'm suggesting 5 steps for you to be able to study smartly within these 3 months. First step is to take a diagnostic test. When I say diagnostic test, these are like topic tests or mock tests or SBA books to at least assess your knowledge on where are your weak points. Okay? This will help you become familiar with the test format and timing. So when you, for example, you have joined the MedExam Expert regular course, we are giving you mock test and topic test. Also, you can find it in our website that sometimes we give mock test, sample mock test in the website. This will help you become familiar of the type of the test and the timing. And research shows that being tested on these materials not only measures your performance, but actually helps you to learn. Second, what is step number 2? You should set your study schedule. I know it's very, very difficult to set up your study schedule because of the demands of work or demands of the family. And some of you are thinking that it's still 3 months ahead. So there is a danger of procrastinating, okay? It is very, very hard to carve out time for studying. And there's a tendency to feel that you have more important things to do today, so you set aside studying. But after that, you don't know, you never realize, you never notice that time has already lapsed. So what you can do is you set a reasonable pace so as not to burn yourself. You don't have to study the whole day. What you can do is in 6 days a week, give 1 day as a rest day. But during those 6 days in a week, you have to study in fragments of pieces. Like, for example, divide it into 3 of 1.5 hours per segment. Because studying most of the days of the week will improve your score compared to studying 1 or 2 days a week straight. So for example, I have to attend something today, I have a duty, it is the birthday of one of my family. So it's okay, I set aside studying and I will study on the weekend like Saturday and Sunday. I think that is not reasonable enough for you to do. What you can do, 1.5 hours, 3 times a day, 6 days a week is better than whole day of 2 days and the 5 days you are procrastinating. So, step number 3. So you have to set up your study plan. So develop your study plan. How you should study. How? Because like you, I also have been through taking my MRCOG part 1, and I know that the syllabus is very very vast. It's very very overwhelming. So you don't know where to start. How you should study. An effective approach is first to use a resource. When I say a resource, these are like organizations like MedExam Expert that will guide you on how you should study. Or not only an organization, like for example, an SBA book or a book. So that is a resource that you have to study to learn the concepts, and then you follow it up by practicing what you have just learned with a test-like question. So first the theory and then the SBA. But it's still very, very vast, okay? But if you join our courses, we lay it out for you, okay? We're the one who developed this strategy. We're the one who developed this study schedule, and you should just follow. What is the importance of doing this is because applying what you learn right away will solidify your knowledge so it sticks with you. So you read a concept, you read a theory, and then you follow it up with an SBA. So you tend to not to forget it. It sticks with you. What you should study? Well, it depends on the test result that you have taken in the step 1. Remember, I told you, take mock exam and practice test to just identify your weak points or your weak parts. And you should focus on your areas of difficulty and the areas that is most often tested. For example, in genetic disorders, genetic disorders are very, very, there are a lot of genetic disorders. So if you study all the genetic information on the genetic disorders like pattern of inheritance and defective genes and the location of gene mutation, believe me, you will be overwhelmed. You will be excited. So you have to see what the areas are being tested most of the time. What are the areas being tested most of the time? For example, cystic fibrosis. You know that it is an autosomal recessive inheritance, and the defect is on the CFTR gene. And the defect of the gene is located on chromosome 7q31. That is the Q arm of chromosome 7, locus number 31. This portion, this portion is not being asked in the exam. So why would you waste time on memorizing the chromosome location of that defective gene? Most of the time, they ask cystic fibrosis, autosomal recessive inheritance, and the CFTR gene, period. You don't have to waste your time memorizing this chromosome location. For example, another example, breast ovarian cancer susceptibility. This is an autosomal dominant inheritance that is caused by your BRCA1 and BRCA2, okay? What is being asked several years throughout the years, what is being asked is the percentage of having ovarian cancer and breast cancer when you have this defective gene. They never ask about the location of the BRCA1 and BRCA2. Okay, so why you waste your time memorizing the location of BRCA1, which is in chromosome 17, Q arm, locus number 21, and BRCA2, chromosome 13, Q arm, locus number 12? Right? You are just digging your grave. You're just wasting your time instead of you focusing on what is the areas that is most often tested. Most probably 1%, sometimes maybe in the whole of 7 years, sometimes it will come out one time. But focusing on these things that are not being most tested is just wasting time. Okay? So you have to know that. So you can see here, these are the division of the subjects for paper 1 and paper 2. So we have here your anatomy, biochemistry, embryology. Okay. You can see here, by just looking at the pie chart, anatomy is always being tested. It occupies a greater percentage of the pie chart. and also endocrinology, okay, and physiology. But I'm not saying you will ignore biochemistry, embryology, genetics, and physiology. Why? Because you can see here, epidemiology and statistics is just almost the same as genetics. And when you combine biochemistry and embryology, it's the same as the portion of epidemiology and statistics. So what you have to do is you have to know what are the areas being tested in these subjects. Don't focus only on the subjects that occupies more of the percentage of the pie chart. So some people, they will only fail by 1 or 2 marks, okay? Because they focus on anatomy, because maybe that is her weak point, and they ignore the other subjects. Why ignore the other subjects when you know that these all subjects are important? Also in paper 2, you can see here clinical management. It occupies a big part of the pie chart, and data interpretation. And you know that this clinical management and data interpretation are the summary of all these subjects that you have studied. So you can encounter anatomy question in the clinical management. You can encounter biochemistry question in data interpretation. So all of these in summary will come, they will be in collaboration, or they will be summarized, or they will be joined together in clinical management and data interpretation. And you can see here microbiology also occupies a big part, which is just the same as your epidemiology and statistics. So you don't have to ignore any little subject, but for every subject, you have to know which are the most common areas or topics that are being tested. Step number 4 that is important in this 3 months time are the important high yield questions, okay? With the word important, okay? This is the recalls. You can hear from your friends or from your seniors that last year the recalls were 50% or 30%. The recalls will never go beyond 50%. Okay, the passing percentage in MRCOG Part 1 exam is from 60 to 65. Sometimes it goes up to 70%. There is only one time that it goes beyond 60, like 57 or 58, like that. So what I'm trying to tell you is, if you study the recalls alone, it will help you pass only 50%. Where will you get the 7%? Where will you get the 10% in order to pass the exam? Of course, that will be based on your knowledge. Recalls are only important because it gives you an idea of what comes out in the exam. Please do not rely on recall keys posted on social media, because it is not reliable unless the source is reliable. So you always have to verify the key. And as I've said, recalls are only 30 to 50% of the exam. They are repeated, but not repeated verbatim. Okay, let me give you an example. In every exam, there's always a question on bacterial vaginosis. And they will give you a scenario, and it will give you choices what is the pathognomonic cells in bacterial vaginosis. So every one of you knows that it is clue cells, right? So those students who tend to memorize bacterial vaginosis clue cells, they stop there. What you can do is, when you encounter a recall question like this, you see bacterial vaginosis, you have to study everything about bacterial vaginosis. You know why? Because the succeeding exam, this is a real example. The succeeding exam, they gave the same scenario, but in the option, there was no clue cells. What the question is, the pathognomonic cells in bacterial vaginosis are clue cells. What are clue cells made of? So if you stop knowing that bacterial vaginosis are clue cells are pathognomonic of bacterial vaginosis, then you will not know what are clue cells made of. You know that clue cells are made of epithelial cells with surrounding bacteria, right? So that's what I'm trying to tell you. Another example is, there was a question on a certain lady after delivery who causes foot drop. Okay, every year they say what is the cause of foot drop. So you memorize already that it is common peroneal nerve, right? And then the next year they gave the same scenario. This certain lady also causes foot drop, but common peroneal nerve is not in the option. So if you stop studying that the cause of foot drop is common peroneal nerve, you will not know that common peroneal nerve is a terminal branch of your sciatic nerve, right? So you don't stop on the keys. You explore the keys. You explore the topic so that you will not encounter this mistake in exam, okay? And step number 5, and I think it is the last step, limit social media. I know all of you are, not all of you, I am guilty also because when I open my phone, I never know that the time passes by just searching for Facebook posts of friends, Instagram, TikTok, okay? Reality is you spend 10 minutes on books and you get bored easily. But you spend hours on social media and not notice that the time has already lapsed. What is the fact why it happens like this? Because social media gives you psychological high and it is a reward cycle. You post something, somebody shared it, somebody likes, somebody comments. It triggers the reward center in the brain. So it gets addicting. So you like, you share, you post, you like, you share, you post, because you get this feeling of reward whenever you are in social media. Please, the solution is what you can do is make learning as addicting as social media. If you cannot limit your social media activity, make learning like social media. What is my point? For example, in genetics, it was very, very difficult for you to understand meiosis and mitosis. There are reliable sources in YouTube that can explain you the facts in a simple manner. For example, Khan Academy or osmosis.org. Okay? So these are reliable sources that can explain you the fact at the medical level, at not a postgraduate level. So what you can do is make learning as addicting as social media. Okay? I know you won't always be motivated, but you must learn how to be disciplined. Okay? This is the one thing that will help you to get through these 3 months. And if you will allow us, we would like to tell you something about our progressive course, wherein all these 5 steps is laid out for you. Okay, from planning, from topic test, everything. So I would like to give you back. If you don't have any questions, I would like to give you back to our course coordinator, Fatima, to tell you about our progressive course before we proceed to the Mpox in pregnancy. Okay, Fatima?
Thank you so much, Dr. Desiree. That was actually very well explained and calculated analysis of how one should prepare in 3 months. So let me just share my screen so that we can talk about this course, as we have been receiving many queries regarding that. So let's start with the progressive course. So I would like to ask all of you, how many of you have been preparing for MRCOG-1 January 25 here? Please raise your hands. All right, Dr. Maria, we have Dr. Maria. And then we have another one, Dr. Aisha. Okay, that's great. So have got you covered on this because we have recently launched this progressive course, which will be led by our senior mentors, Dr. Mohammed Helmi and Dr. Desiree. And then we have our moderator, Dr. Swati. So let's talk about the progressive course. It's basically a solution for you all in which you can maximize your preparation in just 3 months, okay? So in this course, basically, we will provide you with the bundle-wise live Zoom sessions. So there would be around 8 to 7 live sessions in which we cover all the 12 modules. Apart from that, you will be getting the PDFs of all the modules on the website. And as we are done with the live sessions, you will be also getting the topic tests of each and every subject so that you can practice on your own and you can see where you stand in each subject. Once you're done with each and every module, we will provide you with the final mock exam in which you will take or evaluate your overall preparation, and it would be based on the Pearson VUE pattern so that you can be confident about your exam. So then we have the mini mocks, the session recordings of the Zoom sessions. And then not only this, we will also be helping you in the exam booking. As on 29th, the exam booking is opening for MRCOG-1, so we will help you all in that. You will also be provided with the Telegram active study room to discuss daily and share SPAs. And apart from that, the most important thing, which is the exam like questions, you will also be getting those, which are basically recalls. Okay, so these are the recalls, year-wise recalls, which you are getting. Not only that, you will also be getting some complementary workshops like important exam question workshop and biostatistics workshop. So here you can see this is the schedule for the progressive course. We are officially going to start from 8th of November, and we will cover all the subjects in bundles. So now the question is why one should join the course. So if you're planning to start from now, this is ideal for you, okay? For January, if you haven't started yet, you don't have to worry about it. You can just join the study plan, take help from it, and maximum your chances to pass this exam. Also, we will be covering everything in just 3 months, okay? So the whole curriculum will be covered in this. And also, we will be providing you not only the subject-wise recalls, but the year-wise recalls, so that you can enter an exam with confidence. All right, so with a success history of 98%, we would like to welcome you all to join our progressive course. Here are some reviews by our old students, and look how happy they are with the great percentage. This is just to motivate you and show you the success rate. So, okay, so for all of you, those who have attended the webinar, we have a special discount for you. You can join our premium course at 60% off, whereas the progressive course, which is going to start from November, you can join that in 40%. You can directly reach me out. Either you can reach out on the given number. So all the best for that.
Okay, thank you, Fatima. I have here some question from Dr. 111. Ma'am, do we have to pass in paper 1 or paper 2 separately, or total marks of paper 1 and paper 2? It is a combination of total marks of paper 1 and paper 2, but we want you to aim to pass both papers. Why? Because if you fail one paper, that means you have to get higher marks in one paper. So it is better to pass both papers, wherein you will have a little bit of passing in one paper and a little bit of passing, versus you fail one paper and then you have to, you have to make higher grades in paper 2. So it is a combination of paper 1 and paper 2. They don't tell you if you pass in paper 1 and you fail in paper 2, you will fail. No, that is not mandatory. It's a combination of paper 1 and paper 2. But you have to reach the average score that is set for that for your group. Because the passing marks changes. When the exam is very easy for all, the passing marks is higher. Okay, you have any other questions, guys, for Fatima, our course coordinator? You can send messages so we can start our webinar. Okay, let me share my screen.
All right, we have a question here, Dr. Desiree, that what is the difference between these two courses? So,
Okay. You can explain, you
yes,
want? Okay.
sure. Basically, one is the regular course, which is a long-term course, and it has started from August end. So basically, we are covering each and everything in very much detail. The students who have joined regular course experience that everything would be covered in a very detailed manner. Everything is slow and steady, whereas the progressive course, or you can say the revision plan, it's an intense one. Okay, so because we are left with only 3 months, so we want all of you to be a little bit speed up, and we will be like, you should have at least 30 to 40% of knowledge prior to joining this course. You should have covered a little bit of theory, and then you can, start the revision and all. So that is why we are asking the students to enroll early, so that you can get things in advance. You can study from that, and once the course will start, you will have a good knowledge regarding that. So this is the main difference. The duration is what make the two courses different.
Okay, so I have another question here. She said, it's actually a comment. She said that Catherine has a lot of mistakes. Yes, authors are also humans. They make mistakes. That's why we as mentors, we use these resources and then we verify all this. We encountered a lot of mistakes in Catherine, but we correct them during our live session. And also even your Oxford, there are some mistakes because it's an old book. So there are some mistakes in Oxford that we tend to correct during the live session. Ma'am, please recommend books for SBAs. Okay, the books are the same. Catherine, Andrew Sizer, okay, Ankush Raut. What else? Difference between two courses already explained. Recommend books for SBA. A lot of mistakes in Catherine. Okay. Ma'am, I'm MCPS pass in Gynae Obs and have 5 years of experience. Then postgraduate training appreciable for MRCOG 3. What do you mean, Dr. Sobia? Dr. Sobia Suhail, what do you mean? I don't understand your question. Books for theory, Dr. Khan. Books for theory, it depends on your comfortability. For me, I'm more comfortable with um, essential revision because I am not the kind of person who is fond of bullet type, because it's very very difficult for me. Oxford is a bullet type format wherein everything is summarized in bullet forms without any explanation, unlike your essential revision guide, which is a publication by the MRCOG. Of course, that is the #1 recommended book because it has a lot of explanation. How many sessions are there in the course? Dr. Laiba, if you're talking about the regular course, which has already started, the regular course has 12 sessions. It is a subject-wise session. And we already finished, I think, how many? 5 sessions. So remaining 7 more sessions. And for the progressive course, we put them in bundle. So you can see here as Fatima flash on the screen, we have 1, 2, 3, 4, 5, a total of 6 sessions, including the statistics workshop. Okay, these are bundles, physiology and the chronology together, anatomy and embryology. And another thing that is different between the regular course and the progressive course is the regular course is a lecture type, and then you'll have your topic test. For the progressive course, this is question type, question based. So we gathered all those questions that came out in previous exams, and then we explain why that is the answer. So it's like a rationalization of the questions that came out in the exam. Dr. Shahida, I already recommended books for MRCOG Part 1. Fatima, okay. Thank you, Fatima. This one, Dr. Osama, already posted in your chat box the recommended books, Theory and SBA, okay? I want to ask, what is this? Ma'am, I want to ask that 4 years training is required for Part 3, then okay, for Part 1, only eligibility, okay? After Part 2, they will require you training before you enter Part 3. Okay, so you have to pass Part 2 and then you have to provide them proof of your training in order to take your Part 3. MCPS training, MCPS. I'm so sorry because I'm not very familiar with this MCPS in Pakistan. But what the college require is 4 years of training exclusively in OBGYN. So if you are a general doctor, you have to undergo training in OBGYN, and then you have to provide this a residency training. Okay.
Okay, MCPS training will also be counted because it's a structured training, so eligible for MRCOG-3 experience.
Okay. Thank you. Because I'm not familiar with the MCPS. Okay, ma'am. Dr. Aisha, and ma'am recalls will be discussed in the regular course. Dr. Aisha, the recalls are incorporated in the every session. When we give lecture, we incorporate questions in our live session. So that is included in the regular course. And there's also a phase 3 in the regular course wherein there is a revision of all those recall questions. So that is included. Okay. The only difference is in progressive course, um, we discuss this and then we justify why this was the answer for this question. And they will also be included in the exam live workshop. 111. If I want to join the progressive course, so the regular course will carry on side by side with the progressive course. Yes. Because Dr. Helmi, our head of the department, he will make a schedule that this will not be, you know, they will be like, what is that? There's too much questions there. Okay, let me explain first one thing. It will be side by side, but Dr. Helmi make it a point that they will not be conflict with each other. Okay. Is it late to start preparing for January exam? No, Dr. Khan, no. Um, I personally studied, I joined MedExam Expert because before MedExam Expert is only offering 3 months course. We don't have a long course during my time. So 3 months is just enough. Okay. We have to pay for this progressive course, then you allow us to join. Progressive course, Dr. Sobia, if you are a member of the regular course, progressive course is a different plan. So if you are enrolled in the progressive course, in the regular course, and you wanted to enroll in the progressive course, yes, you have to pay, but I think they will give you special discount because you are a member of the regular course. How much is the fee, Dr. Laiba? Dr. Osama will talk to you. Okay? Any more questions, guys? Let's go to the very important webinar, educational webinar topic on Mpox. Mpox is a part of your microbiology module, okay? And for part 2, for those of us who join part 2, it's also very important. So let me share my screen. You can ask all your questions later on after the webinar if you still have more questions about the course. Okay. So Mpox in pregnancy, as you all know, this is monkeypox, okay? Monkeypox in pregnancy. And recently, the World Health Organization has changed its name into Mpox because of some racial issues. Because, Mpox has been stigmatized among gay population and the men who have sex with men. So they raised up to change this. So the name monkeypox and Mpox are being used side by side. However, after 1 year, monkeypox will totally be erased and all healthcare system will be using only Mpox. Okay, so it pays to be always updated. Our reference for this webinar is the joint guideline by the Royal College of Midwives and the Royal College of Obstetrician and Gynecologists. This is the first version of this guideline published last year, November 2023. This will be the overview of our webinar for today. We will be talking about introduction and epidemiology, Mpox, presentation, diagnosis, vaccination, antenatal care, labor and birth, post-birth neonatal and maternal care, early pregnancy loss or termination, and psychological and social considerations. As an introduction, let me tell you something about Mpox. So Mpox is a double-stranded DNA virus. Okay, you all know, or if you have not yet touched on microbiology, all DNA viruses are double-stranded except for one, which is the parvovirus. It is a single-stranded DNA virus, okay? And Mpox belongs to the Paxviridae family under the genus Orthopox virus. It is the largest DNA virus and the only DNA virus that replicates in the cytoplasm. All DNA viruses replicates in the nucleus, but Pax viridae replicates in the cytoplasm. The first outbreak for Pax virus were noted in research monkeys in Denmark. And the first human infection was noted in 1970 in the Democratic Republic of Congo with a case fatality rate of 10%. That's why it was considered the high consequence infectious disease. Also, in 1970, it was the first outbreak outside Africa, which was in the US. However, the most serious outbreak happened in 2022 in UK, wherein there were 3,345 cases. However, this is the non-HCID, that means non-high consequence infectious disease, with a case fatality rate only of 0.5 to 1%, not like the first one in Congo with a case fatality rate of 10%. There are actually three pox viruses that infects humans. Okay, you can see here variola, which causes your smallpox. Let me open my laser pointer. So you can see here variola, which is caused by which causes your smallpox. You have the vaccinia. When you say vaccinia, these are the vesicular vaccination lesion. So when the smallpox become pandemic, they invented a vaccine for the smallpox, and they noticed that at the area of the vaccination, there is a lesion that erupted, and they call it the vaccinia virus. So this is an artificial virus that is caused by your vaccination. And another one that another pox virus that infects human is molluscum contagiosum. It causes multiple skin nodules, raised papules, dome shape. Okay, you can see here monkeypox. Let me open my. You can see here monkeypox is only seen in monkeys and squirrels, and it resembles the smallpox. Okay, before, but now it also infects humans. So there are two types of monkeypox or Mpox virus. You have your clade 1, which is more endemic, okay? And it is more severe and has killed 10% of those who are infected. Okay, this is more severe, clade 1. And then we have your clade 2. This is the cause of the 2022 outbreak in UK. This is less severe, okay? It started in United States also. Mpox is still spreading in the United States, it's small cluster. Clade 2 has sub classification, like your clade 2A or clade 2B. So this is the phylogeny of clades. When you say phylogeny, this is how the virus are interconnected with each other. You can see here clade 1 and clade 2. Okay, clade 2 has two different subtypes, your 2A and your 2B. And 2B is the one that causes your outbreak in lineages. Okay. So how it is transmitted? So transmission has two types, animal to human and human to human. Okay, when you say animal to human, this is caused by contact with infected animals carrying Mpox via bites or physical contact, eating undercooked meat of an infected animal. When you say human to human, this is close physical contact, such as skin to skin or sexual activity with a person who has an active vesicular rash, or contact with the clothing or bedding used by an infected person, or droplets in air when an infected person has cough or sneezed. Okay, vertical transmission is also considered human to human, and the WHO has reported that transmission of Mpox virus can occur both via the placenta or via close contact through passage through the birth canal. So this is how it is transmitted. We as obstetrician gynecologists, you are more concerned on the effect on pregnant women. So what is the effect on pregnant women? There is actually very little known about Mpox infection in pregnancy. As you know, it is very recent in 2022. So very little is known about Mpox in pregnancy, labor, and postpartum period. But since they say that Mpox resembles smallpox, and smallpox, which also belongs to the orthopox virus genus, which was associated with poor maternal and neonatal health outcome, when infection occurred in pregnancy, they say, scientists and researchers say, that Mpox has the potential to cause severe disease in pregnancy. So it seems reasonable to suggest that infection in pregnancy may cause severe and poor maternal and neonatal health outcomes. So what is the presentation and diagnosis of suspected Mpox in pregnant women? So in pregnancy, if someone is concerned that they may have Mpox, they should be referred to the local genitourinary medicine or infectious disease specialist for further advice. This can be done by either the GP, the midwife, or the obstetrician. However, if a pregnant woman who is concerned with Mpox and is in active labor, it is the responsibility of the midwife to alert the maternity unit at their local hospital. If a pregnant woman with suspected Mpox is confirmed, okay, it should be reviewed by a person, the GM clinician or infectious disease specialist, who has more experience in assessing Mpox if possible. Of course, healthcare professionals should always wear PPE, like during the COVID pandemic, in line with the UK Health Security Agency guidance. Okay, pregnant women, whenever they call you that I feel that I have an Mpox virus, they call you, you have to tell them to come to the hospital using their own vehicle and make sure that all the lesions are covered. So what are the case definition of Mpox? So we have 6 types. When you say possibility, okay? There is symptoms, and there is a prior contact with the confirmed case. So when you say symptoms, these are the symptoms: chills, headache, exhaustion, muscle aches, myalgia, arthralgia, okay? And there is a known prior contact with a confirmed, you see here, confirmed case. I will tell you later on what is a confirmed case. In the 21 days before the symptom onset, okay? Or an illness wherein the clinician has suspicion. So a patient comes in and the clinician think that this is Mpox, but the lesion is unexplained. So this is possible case, okay? When you say probable, what is the difference between possible and probable? Probable, there is already a rash, okay? Like here, no rash. Only febrile prodrome, only prodromal symptoms without the rash. Probable, that means the suspicion gets higher, okay? There are lesions in any part of the body, okay, including proctitis like anal pain and bleeding. And there is also epidemiological link to a confirmed case. That means she has a contact 21 days before the onset of symptoms, or she has had one or more new sexual partners in the 21 days prior to the symptom onset. So possibility, only probable, it increases the possibility. And when you say highly probable, the patient gets positive with orthopox virus. You remember, monkeypox virus belongs to the orthopox virus genus. So the patient becomes positive for orthopox virus PCR, highly probable. But if the patient becomes positive with Mpox PCR, then that is confirmed. You know the difference? This is the genus, this is specific for Mpox. Just like your VDRL. When a patient is positive for your VDRL, it doesn't mean that she has syphilis, right? That means only that she has treponemal infection. You are not sure if this is a jaw, Yo, Pinta, or Begel. You don't know. But you only know that she has treponemal infection. Also here in Mpox, when the patient becomes positive with orthopox virus, you don't know whether this is a smallpox or whether this is vaccinia or whether this is Mpox because they belong to the same genus. But when the patient becomes positive for Mpox PCR, then it is already confirmed. Okay? Unlikely. What is unlikely case? When you say unlikely, this is a pregnant woman with no signs or symptoms of Mpox, no rash, okay, and a negative PCR case. So of course, it's impossible that this is Mpox, okay? And when you say that a pregnant woman with an established alternative diagnosis, when you say alternative diagnosis, it could be like anything that causes the rashes, like your herpes simplex, right? When you say high risk, what puts you at high risk? These are the people with underlying healthcare condition or immunocompromised individuals, like a pregnancy. It's an immunocompromised state. People who have had close contact with patient with confirmed Mpox, for example, sexual intercourse, or an Mpox positive person via household contacts, and us as healthcare workers caring for confirmed cases of Mpox. We are at high risk. Okay? So what are the types based on severity? We have your mild to moderate. There are presence of skin lesion, but with absence of any features of severe disease. And there is a severe disease, mild to moderate and severe. Severe disease, when you say severe disease, there is severe refractory pain, okay? Secondary bacterial infection, numerous lesions, okay? Lesions everywhere, inability to swallow, constipation, encephalitis, and pneumonitis. These are considered severe disease. So what are the risk factors for Mpox? What will put you at risk? Of course, when you get in close contact with a known infected individual, direct contact with contaminated materials such as bed linen, recent travel to a country where Mpox is endemic, like Africa, it is endemic in Africa, contact with animals that are known carriers of Mpox, like rodents, rogue squirrels, tree squirrels, Gambian pouch rats, okay, dormies, and non-human primates, or in any pregnant women displaying signs and symptoms of Mpox. What are the symptoms of Mpox? Mpox typically develop 5 to 13 days post exposure to the virus. We have the prodromal phase, wherein you have your flu-like symptoms. We have the vesicular rash, and the rash can last for up to 4 weeks. The rash has stages. Okay, the stages of the rash, first are macules, then it becomes papules, then it becomes vesicular, becomes pustular, it crusts over, and then it heals. You are just considered healed when the crust have fallen off and there is you see residual new tissues on the skin. And this is a total time of 2 to 4 weeks from the time you have the macules until the time it heals. Okay. So how you diagnose Mpox? Of course, full comprehensive history, full examination of the skin, and a PCR or polymerase chain reaction, okay, should take place in discussion with your multidisciplinary team. The following samples should be taken, multiple swab samples should be taken on open source vesicles and placed in a viral transport medium. Viral throat swab can also be used. Okay. You have to exclude, before you diagnose a patient with Mpox, you have to exclude other conditions present with similar symptoms like your HSV1 and HSV2, enterovirus, varicella zoster, syphilis. Enterovirus because when the lesion happens to be in your anus, there will be like proctitis, anal pain, and bleeding. And if it is indicated, you have to do full sexual health screen for HIV, HCV, HBV, and a PCR for Neisseria, chlamydia, and mycoplasma. Visitors to pregnant women with suspected Mpox is discouraged until it has been assessed that the patient is free of the disease. Okay. If a positive result is received, this is very important. This should doctor should notify the local health protection because this is a notifiable disease. Okay. What consists your MDT, your multidisciplinary team? Your virologist, microbiologist, infectious disease consultant, obstetrician, neonatologist, midwife, and anesthetist if the patient is about to deliver. Isolation advice exposed to Mpox, okay? So pregnant women exposed to Mpox should follow the UK Health Security Agency guidelines on self-isolation. However, isolation is not required for those people who have contact with people exposed to clade 2. Remember, these have very low case fatality rate. Pregnant women with confirmed Mpox should isolate at home. Okay, so at home isolation only. So you can see here there are stages of, there are clinical criteria. When the patient has been assessed over the telephone or video call, and has been afebrile for 72 hours is considered systematically well. Okay, lesion criteria for which she is already well, no lesion in the 48 hours, in the past 48 hours, no oral mucous membrane lesions, all the lesions have crusted over, and all the lesion on exposed skin have scabbed over, okay, and drop off, and there's a new fresh layer of skin underneath. Lesions on the other areas should remain covered until patient's time outside of their home when in contact. So whenever the patient goes out of the home, the lesion should be covered. But it's preferable that she stays at home until the local health authority cleared her that she is okay to de-isolate. Okay? So as a supporting text to this, Mpox in pregnancy is rare. When a pregnant woman or postpartum woman presents with a vesicular rash, it is very important to rule out first other potential diagnoses such as what I have mentioned before. Okay? And the UKHSA guideline has published appropriate use of PPE on Mpox infection. I know all of you are aware of this. It's the same guideline as in the COVID-19 pandemic. So vaccination following exposure to Mpox in pregnancy. So there are two types of vaccine that is allowed by the UK HSA. Okay, they recommend the modified Vaccinia Ankara, Bavarian Nordic, or the MVA-BN vaccine on a case-to-case basis. Okay, case-to-case. Possible risk should be explained as to the type of exposure, which I will show you in tabulation in the next slide. The decision to vaccinate should be made by the multidisciplinary team. And the MVA-BN vaccine should be given within 4 days of exposure. But if you miss the 4 days, it can also still be given within 14 days. Okay, this is supporting text about the vaccine. This is a non-replicating vaccine, so it is theoretically safe in pregnancy. There's another vaccine that you can use, which is the smallpox vaccinia vaccine or the ACAM 2000, which confers cross-protective immunity because they belong to the same, they target the same genus as the smallpox. However, you remember that after vaccination with the smallpox vaccine, there's a risk for vaccinia, which is a synthetic virus caused by the vaccine. So there is a small risk of fetal vaccinia. Okay? So how do you monitor during pregnancy? Antenatal care for pregnant women with confirmed Mpox, okay? Usually, it is the clade 2 that infects the pregnant women. They don't need hospital admission. They need to be assessed regularly by a GUM specialist. They have to have regular check-ins with their community midwife. The check-ins can take place virtually, okay? So that means you don't have to go to the hospital putting at risk all other patients. You can check in virtually with your midwife, and the midwife should liaise with the obstetric team or the local infectious disease specialist or the GUM specialist. Contacts of pregnant women with Mpox should be assessed for the need of vaccination by the health protection team. Okay, what else? You should teach the pregnant women how to manage their symptoms. This is like a symptomatic treatment, like antipyretics, analgesics, because the lesion could be very painful. And ultrasound scan should only be offered as clinically indicated. So how do you care for the Mpox rash? Okay, analgesia should be given. The nails should be kept short to avoid damage when itching. Topical anesthetic such as lidocaine. Mouthwash if there are oral lesions. And if any markers of severe disease, like we have mentioned before, there's the need for hospital admission. Okay? So this is the trimester-specific risk for monitoring advice. So the first trimester, the risk of miscarriage is there and vertical transmission is there. For the second trimester, also the risk of miscarriage and preterm birth and the risk of vertical transmission. And in the third trimester, there is a risk of preterm birth and intrauterine death. So what you can do, advise the patient, counsel on symptoms of miscarriage, vaginal bleeding, or pelvic pain, and provide reassurance with regards to vertical transmission. Consider ultrasound scan. When you do amniocentesis, you take the sample for Mpox PCR. And again, ultrasound only if clinically indicated. And the third trimester, you have to counsel women regarding reduced fetal movements and weekly evaluation with ultrasound Doppler if possible. Secondary care for admission. So pregnant women with severe Mpox infection should be admitted to the hospital. Remember, severe only. The mild and moderate, no need for hospital admission. And when they are admitted, they should be in a single room with ensuite facilities. Okay? There is very little knowledge on the treatment of Mpox. So the treatment involves only the best supportive care. However, there are antivirals, but these antivirals are not for pregnant women. Okay? The antiviral treatment that is recommended by the UK is tecovirimat, brincidofovir, and cidofovir. Okay, for non-pregnant women. For the tecovirimat, sometimes if the need is there, they allow it to be given to pregnant women because there is no teratogenic or embryotoxic effects. However, it is not very recommended unless the disease is severe because there is insufficient evidence. Okay, so it is not recommended unless the benefits are considered to outweigh the risk. Although it is non-teratogenic because there are no studies that has been done, so the benefit should outweigh the risk. Breastfeeding should be discontinued because data have shown that these antivirals are excreted in milk. The US FDA advises brincidofovir to be avoided in pregnancy and cidofovir because they are teratogenic on animal studies and should not be considered in pregnancy. So for this antiviral, 3 antivirals, only tecovirimat is allowed in pregnancy on case-to-case basis. So what are the maternal and obstetric monitoring requirements for patients with Mpox? Of course, observation at least 4 times a day. This includes your blood pressure, heart rate, oxygen saturation. And if more than 26 age of gestation, cardiotocography is recommended to be determined by the fetal medicine specialist. During acute infection, you can do ultrasound assessment as clinically indicated. And on acute, once acute infection has resolved, you can do 4 weekly ultrasound scan to check for fetal growth, anatomy, and amniotic fluid assessment. Treatment options, this includes your thromboprophylaxis, the same as the guideline, the UK, the Green Top guideline, okay? IV fluids only if there is difficulty, if there are lesions in the throat or the mouth and the patient cannot eat. So IV fluids is recommended based on their fluid status. Oxygen, if the oxygen saturation is less than 95%. Routine antibiotic prophylaxis is not necessary unless there is secondary bacterial infections from the lesion. And antiviral treatment, as we have mentioned, may be considered in unwell pregnant women in conjunction with appropriate infection expert, okay? Regular monitoring of full blood count, C-reactive protein, and liver and kidney function is recommended for those with severe infection. So regular monitoring only for those with severe infection. How about during labor and birth? What will happen if the patient has Mpox infection? Mpox infection, once diagnosed, is not an indication for iatrogenic preterm delivery. However, if there is evidence of maternal and fetal compromise, the decision should be taken into account just like your regular obstetric indications. Check the gestational age, the estimated fetal weight, and whether the woman will benefit from earlier delivery. Of course, you have to give magnesium sulfate and corticosteroid for lung maturation. However, you have to take note that corticosteroid may cause deterioration in the maternal condition because of their immunosuppressive. So you weigh the benefits against the risk. You have to consider the maternal benefits first. As you may know, in the ethical portions of, in the ethical consideration, an unborn child has no right, okay? So your aim is always to save the mother first. If you can save both, then that is good. So at present, the optimal mode of birth. So what will happen? The patient has to deliver by normal delivery or via cesarean section. So at present, there is no optimal mode of birth in pregnant women with Mpox. Okay, but in cases where you can see that there are genital lesions, of course, it is better to deliver by cesarean birth. And without genital lesions, you have to explain to the women that there is absence of data whether cesarean will benefit because there is no genital lesion. And you know that Mpox can be transferred to the baby through passage through birth canal. Okay, in all cases, women should be given the opportunity to discuss the modes of birth, and the woman has the right to make her choice based on informed decision. Okay. Uh, Review by obstetric. So this slide is only about the anesthesia. Okay. So if the obstetric analyst, if the delivery should take place, so the lesion should be, because there are lesions sometimes in the area of spinal anesthesia. Okay. And sometimes oropharyngeal lesion may complicate intubation. Okay, so you have to discuss this to the patient, all of these complications. And the staff taking care of the pregnant women with Mpox should be always wearing PPE. Okay, PPE should also be provided to a birth partner because in UK there should be a birth partner. It doesn't have to be the husband. It could be your mom, your friend. If the chosen birth partner is allowed to attend the birth, then PPE should be provided to the birth partner. About delayed cord clamping, so delayed cord clamping is recommended whether it is cesarean or vaginal birth because there is no evidence that there is increased transmission risk with delayed cord clamping. Okay, and delayed cord clamping, are well recognized. There are well recognized neonatal benefits for it prevents anemia, okay, and infection. Infection prevention and control measures should be followed at the disposal of the placenta or any other fluids for the infected pregnant women. How about after birth? After birth, specialist advice should be sought. Okay, um, regarding for the baby, there are infectious centers as mentioned here. And a baby born to a woman with confirmed or suspected Mpox should be considered infectious. So whether it is confirmed or suspected, it should be considered infectious until a negative PCR test has been done. So all neonates born to mother should be tested for Mpox infection using PCR of throat swab or blood, urine, or swabs of any vesicular rash. If the baby is not infected, then in order to reduce the risk, the mother and the baby should be separated at birth. Okay? So if the baby has tested PCR negative and the mother is PCR positive, there should be no latching in. The baby should be separated from the mother and close skin to skin contact should be avoided. The baby should be also isolated from the other babies in the side room until the negative PCR has arrived. So if you're not sure that the baby is PCR negative, the baby should not be joined with the other babies in the nursery. If the mother refused separation, the MDT should discuss, okay, the risk that she will be giving to the baby. The mother and the baby can be reunited only if they are both PCR positive or they are both PCR negative. So of course, that separation happens. There should be a need for mental health support. Okay. If the mother is confirmed positive for Mpox and the baby is negative, then you have to give vaccination to the baby as soon as possible as prophylaxis. Breastfeeding is not recommended unless both mother and child are infected. So if a mother is PCR positive and the baby is PCR positive, no problem to breastfeed. However, if the baby is negative, then breastfeeding is not recommended. And breastfeeding only resume once the mother is no longer considered infectious. Okay, persons who have positive contact with people with Mpox should not donate breast milk within 21 days of exposure. Okay, what else? Postpartum, given there is no risk to the fetus, antiviral treatments can be considered. If the woman is severely unwell, postpartum, you can give the antiviral treatments because she's no longer pregnant. And there is no current evidence risk to future pregnancy once the patient has fully recovered. Okay, and you should give contraception according to the UK guidelines. How about early pregnancy or loss or termination? If the patient has early pregnancy loss or patient has wanted to terminate the pregnancy and she has an Mpox, okay, it should not prevent suspicion or confirmation of Mpox should not prevent delay or access to abortion care in women choosing to end the pregnancy. So once she is infected with Mpox, the treatment should not be delayed. Okay. There should also no delay in management of early pregnancy loss in women with Mpox. However, precautions should be taken and the patient should be in a single room, just like the previous slides, and the staff should wear PPE. And as I mentioned, no evidence that future pregnancies will be affected by Mpox once the patient recovered from Mpox. And you know, as because these Mpox carry a big stigma to the pregnant patient, of course, you have to give psychological and social considerations to these individuals. This is the algorithm of what we have discussed a while ago. Okay, so the red ones are your key points for obstetric management, and the blue ones are the key points for medical management. Okay, it's the same as what we have discussed. You can see here, pregnant postpartum women develop signs and symptoms. You can just read this slide, okay? Read this algorithm. And if it is negative, of course, you see no other pathology, no further follow-up required. If it is positive, then you have to go to this algorithm. It is mild to moderate. If it is severe, mild to moderate, no need for admission. Severe Mpox, of course, healthcare ideal. You have to have hospital care here, severe Mpox, hospital care, obstetric care, supportive care. Okay, so this is just what we are talking in the last previous slides. And there's this algorithm can be seen in the second page of the published guideline. And this another algorithm can be seen as an appendix in the last page of the guideline. So pregnant women with PCR confirmed Mpox, you have mild, moderate, and severe, the same. Okay, the same as what we have discussed. Okay, but this is just a summary. Okay, so guys, that ends my webinar. If you have any other questions about Mpox, about the course, you are free to do so. Anyone?
Dr. Desiree, do you know
Yes.
about part 2 in
Uh-huh.
January 2024? Any question about Mpox came?
January 2022, no. You know why?
No,
Because
24.
yes, 2024, no. You know why? Because the guideline was published only in November 2023. You have to expect 6 months, 6 months to pass before they can make another exam question. So probably in July 2024, maybe there's, I'm not sure. Okay, I'm not sure if there's a question, but most probably in January of 2025, there would be um, questions about Mpox. You know why? Because in July 2024 that it was I think declared to be endemic in certain parts outside Africa. So when there is a new virus, you have to expect, like before the Zika virus, the COVID-19. You remember it came out in the exam. So expect that in January 2025 there will be some questions on Mpox for part
I
two.
mean in part 2. Of
It's
course, they
in
will
part two.
bring part
In part 2, this
2.
will be for management.
Thank you.
Part 2 will be for management of Mpox in pregnancy. And for part 1, it will be about how transmission of Mpox for microbiology.
And how I can take this
Guideline.
guideline?
Okay, you can just search Mpox in pregnancy, join Royal College of Midwife and Royal College of OB/GYN recent guideline. It's free, downloadable. There are two versions, the long version, which is 100 pages, and the summarized version, which is 22 pages. You
Okay,
can
thank you.
just simply, get the summarized version.
Thank you.
Welcome. Anyone else? Question? Dr. William Kwame Tando. If you are on the course with regular course, you have to necessarily join the progressive course. The regular course will provide you everything. It is a long course.
Why
Uh,
people are throwing here?
the progressive course, hello, Dr. Archana, wait. Okay, the progressive course is for those people who are in a rush and have not joined the regular course. However, those who are in the regular course who wanted to brush up on these certain points, wanted to revise, can also join. We have several students before who joined the regular course and also joined the progressive course. But this is a fast-paced, Dr. William. Progressive course is a fast-paced course, not unlike the more relaxed course in the regular course. Because in the progressive course, we expect you to have a little knowledge, background knowledge, and this is, as I've mentioned, a question and answer portion. Okay. Dr. Archana, what are you saying? Thank you, guys. Dr. Lily Tulip. Thank you, Techno Mobile. Too many chats here. Thank you. So any other questions? Ma'am, on which subjects mostly first to focus? Dr. Sobia Sohail, you focus first. I showed you some pie chart, right? You focus first on those who occupies most of the pie chart, but don't ignore all the other subjects. Thank you very much, ma'am. Okay. Thank you, Dr. Laiba. Thank you. Thank you, Dr. Lily Tulip. Lily Tulip, those are two different flowers, huh? Lily and Tulip. Nice name. Thank you, Aisha. Ma'am, what is case by case? Dr. Aisha, what you mean case by case? Case to case basis. If there's severe infection, you mean? If there's severe infection, then you can give the vaccine. You have to weigh the benefits over the risk. Which course to select now if I want to join? Okay, Dr. Khan. Now you are in 3 months. If you don't have any knowledge, basically zero knowledge, you can still join the regular course if you want, because we are still halfway through. Okay, we are halfway through the regular course, and you can have. However, if you join the regular course, you will be provided the recordings only the recordings of the live sessions, so you can still have access to those recordings. Okay, however, it is different, different when like this in a webinar, there's interaction. It's different when you are in the regular course, that you can interact with your mentor right away. Okay, it's very, very easy. You retain more if you are interactive rather than you're just listening to the lecture recorded session. Messages. Dr. Sobia, because you are enrolled in the regular course, this webinar will be available in your platform under microbiology. However, since this is a webinar free for all, you can find this recording immediately in our YouTube channel and our Facebook page. Dr. Techno has a message. Happy to see you in Progressive Coach. I hope all lectures will be like this webinar. Of course, we will do our best. Satisfied. Thank you, Dr. Roxana. See you in the progressive course. Thank you, guys. Thank you so much for spending your weekends with me. Your comments are heartwarming. I'll see you. We will see you in the progressive course. Okay. Any more questions? If not, we can call it a day. Happy weekend, guys. You can contact the team if you have any other questions. Okay. Bye, guys.